Hello everyone, so we're going to continue our discussion. Let's say you have 33-year-old woman came in with palpitations and anxiety, and she's been trying to lose weight. This is always a red flag, like an endocrine section, when there's trying to lose weight. Okay, so you do a regular lab, thyroid panel, right? You do TSH is 0.01. You do free T4, it's like 0.9. It's very low, both of them. But here's the shock: when you do T3, it's 340. This is very high, normal, like 60 to 80. So what's the diagnosis? This is factitious thyrotoxicosis. Okay. So this is factitious thyrotoxicosis. And there's low radioiodine active radioiodine uptake. So what are the differentials of thyrotoxicosis with low radioactive iodine uptake? If there is painless thyroiditis, like silent thyroiditis, lymphocytic thyroiditis, subacute lymphocytic thyroiditis, postpartum thyroiditis. If there is decovariant thyroiditis, like subacute granulomatous thyroiditis. If there is iatrogenic, like somebody taking lithium, amiodarone, iodine, interferon, interleukin-2, all of these can cause thyroiditis. Factitious ingestion of T4 or T3, if they're just taking it to lose weight. Struma ovarii is another one, causes low radioactive iodine uptake. Acute thyroiditis and extensive thyroid cancer metastasis can cause thyrotoxicosis with low radioactive iodine uptake. So this is to keep in mind. Thyrotoxicosis with low radioiodine active uptake. Okay. This can happen with medications, exogenous ingestion, cancer, decovariant thyroiditis, postpartum thyroiditis. Okay. Now they ask you about the patient. 45-year-old woman came in with she had thyroidectomy, and then she has TSH of like 2.5 and taking levothyroxine. And they tell me, what is the risk of low thyroid in this patient or in general? Okay, risk is osteoporosis, man. That's why you give thyroid, because if you have low thyroid, the bone is gonna be slow and wouldn't be built as usual, so it causes osteoporosis. Okay. Another question, they bring you 66-year-old woman comes in with they give you T-score like between 0.1, -1, -2, and then you only need one value, -2.9, one value, and they give you a bunch of other values. That's all what you need to know. They tell you, okay, what to do next. What to do, my friends? Diagnose osteoporosis and discuss treatment. This is osteoporosis. You only need one. The osteoporosis is a metabolic disease. Can happen if it happens in one bone is low, then this everywhere is low. Okay, it's not like one bone osteoporosis, one bone doesn't. If it's one bone, then it's the whole body. Okay, so how do you diagnose osteoporosis? Either T-score -2.5 or less, or history of fragility fracture. Low bone, if it's -1 to -2.5, this is just osteopenia, low bone mass. If it's -1 or greater, this is normal. That's how it should be. Okay. So now you have 71 with a prostate cancer, taking leuprolide. They tell you what is the risk, what's causing the issue. Okay, what is complications of that? This could cause osteoporosis. Leuprolide, it suppresses androgen and causes osteoporosis. So now that brings us, what else can cause osteoporosis in man? If there is androgen deprivation therapy, like in this patient, or hypogonadism, like in leuprolide. If there is hyperthyroidism or parathyroidism, here in the neck issues, any hormone goes up causes that. If there is a steroid or anticonvulsant, you can have osteoporosis. If there is GI issues like inflammatory bowel disease, celiac, like you're not absorbing calcium or vitamin D, this is causes osteoporosis. If you don't have sun exposure or you don't take vitamin D, also can cause osteoporosis. Smoking, alcohol, and history of fracture or falls, all of those can increase risk for osteoporosis. Okay. Now you see a patient, 34-year-old woman, comes in with fatigue and difficulty lifting weight. So exam, there's facial plethora, fat and supraclavicular and posterior neck. Okay, and then they tell you, okay, what to do, what's best next step, and they give a bunch of cortisol tests. The best one here, you do late night salivary cortisol. Okay, that's a very important test to order, and there are factors interfering with Cushing's syndrome screening test. There is with the overnight dexamethasone suppression test could cause false positive result, like high cortisol binding globulin. So there are three tests to detect Cushing's syndrome. Okay, there is dexamethasone suppression test, there is a 24-hour urinary free cortisol, and there is late night salivary cortisol. Okay, so when do you do each? Okay, late night salivary cortisol, usually anybody age more than 60 may have elevated level, and it's not best for somebody who work night shifts. Okay, erratic sleep wake cycles. Okay, so this is a good one to start with. Okay, to how about 24-hour urinary free cortisol? Okay, there are a few things that interfere with the 24-hour urinary free cortisol, like carbamazepine, fenofibrate, synthetic glucocorticoid, and licorice. This can have false positive results. Okay. How about the dexamethasone suppression test? There's a bunch of things that could cause to have false positive result. If there is high estrogen or mitotain, this is going to increase the cortisol binding globulin. If there is something that increases dexamethasone metabolism, like phenytoin, anticonvulsant, like carbamazepine, phenobarbital, rifampin, rifapentin, paclitaxel. Okay, so RRPP, rifampin, rifapentin, phenytoin, paclitaxel. Depression and alcoholism as well can cause false positive results. So you need 2 of these tests to confirm Cushing syndrome. Okay. So now another case that's tricky is and high yield. It's important to know that they tell you 42-year-old woman, diabetic, and have iron deficiency anemia. Okay, so look how they connect the two. So they say hemoglobin is 9, and the hemoglobin A1C is 7.6, and then they tell you what to do. This next step, you treat with iron, or do you increase the insulin, her insulin dose? This patient could be iron deficiency anemia because it's falsely elevated hemoglobin A1C. So honestly, what you need to do, you just repeat A1C, give iron, repeat A1C in 3 months. Okay, this is high yield. A lot of people have iron deficiency anemia and diabetes, so you gotta know. So there are non-diabetic conditions that affect the hemoglobin A1C. If there's increased A1C, like iron, folate, B12 deficiency, splenectomy, and polycythemia, increase hemoglobin A1C. What are the things that decrease hemoglobin A1C? If there is hemolytic anemia, sickle cell, or red cell transfusions, or use of erythropoietin, these decrease hemoglobin A1C. Falsely decrease hemoglobin A1C. And the one that increase falsely elevate hemoglobin A1C, splenectomy, polycythemia, iron, folate, B12 deficiency. So alright, now someone 40-year-old obese man on orlistat to lose weight. Okay, what do you do? Recommend low fat diet. This is something you need to know. Fat, because fat, if you take more than 30% fat intake, this is going to cause similar effect to fat malabsorptions like flatus, fecal incontinence, oily spotting, okay? And lower fat intake is going to decrease that, okay? Why? Because of the mechanism of this orlistat. It's used to treat obesity by inhibit pancreatic lipase to reduce fat absorption and increase fecal excretion. So inhibit the lipase so that you don't dissect. So you just eat and poop the food that you eat. You don't absorb it, okay? This is orlistat, okay? Now, you see somebody who's who wanted to go do surgery, need hemicolectomy for colon cancer, whatever. But the patient is also on SLE and have high dose steroid, and they tell you, okay, what to do. What to do? You do give stress dose steroid perioperatively, okay? You give stress dose steroid before the surgery. This is the. Now that brings us to the discussion of steroid management, okay? So, what are the risks of hypothalamic pituitary adrenal suppression with chronic steroid therapy? Okay. The ones that are taking less than 5 milligram morning steroid and less than 3 weeks, or 10 milligram every other day, this one there is no risk for suppression. But if the one they're taking 5 to 20 milligram for more than 3 weeks, or there is evening dose of 5 milligram, not morning, or they had a history of long duration of steroid, or they take inhaled steroid for more than 3 weeks, or more than 3 intra-articular or spinal steroid in the past 3 months, this is intermediate risk. So you need a pre-op evaluation for steroid would be helpful. Which ones that are high risk? The ones that are very high risk, if you have daily prednisone more than 20 milligram for more than 3 weeks, and any patient taking glucocorticoid who had Cushingoid features, like buffalo hump, central obesity, moon faces, weight gain. These people, you need to stress those steroid recommended, okay? So usually I tell you the patient taking very high dose of steroid, what do you do now? You just give pre-op steroid. Okay, now the question about triglyceride management. So 52-year-old have triglyceride of 480. What's best next step? You just give rosuvastatin, okay? So you may ask, why is that? Because, so if there is a triglyceride, usually someone triglyceride, you evaluate for secondary causes. And if it is below 500, like 150 to 500, you recommend weight loss, moderate alcohol intake, exercise, and then if there is high risk cardiovascular disease, you just give atorvastatin. If it's above 1,000, then the goal is to prevent pancreatitis. So that's when you increase risk for pancreatitis. You give fibrate fish oil, abstinence from alcohol. And once it goes below 500, you just discontinue fibrate fish oil. Okay, now this case is interesting. So if you see 64-year-old woman comes in with weakness, okay, a muffled heart sound, and you do echo. So okay, muffled heart sound, and then you do echo, showed pericardial, mild to moderate pericardial effusion. So they're just asking you how do you work up pericardial effusion? Okay, so they give you CBC, BMP, okay, and then one of the tests is you do thyroid function test. Okay? Others you do CBC, BMP, but you want to check thyroid because it can cause moderate pericardial effusion. Okay, other tests you can do anti-double stranded DNA and complement levels. Okay, as well. You anti-double stranded DNA complement level. So, because one of the manifestations of hypothyroidism is you cause pericardial effusion, okay, or cause decreased cardiac output due to decreased cardiac contractility. What are the other features of hypothyroidism? Other features are dyspnea, bradycardia, hypertension due to increased peripheral resistance, peripheral edema as well, usually non-pitting but less commonly pitting. It can cause ventricular arrhythmia, cause increased risk for coronary artery disease, because increased cholesterol as well, hyperlipidemia as well. So it's pretty risky, you know, can cause a lot of stuff. So now 51-year-old diabetic, BMI 39. What's best next step? You do bariatric surgery. It's the one that achieve good glycemic control. They'll tell you, okay, how do you achieve good glycemic control? It's bariatric surgery. What other features for other medications that help diabetes, for diabetes? So we have 5 things that are they're very important. Metformin is go-to. Metformin, sulfonylurea, pioglitazone, sitagliptin, and exenatide. Okay, so these are 5 common ones. Metformin usually can decrease they all can decrease the hemoglobin A1C, but each has different features. Metformin is the preferred initial, and it's weight neutral and doesn't cause hypoglycemia. Okay, and cause lactic acidosis. It's a rare life-threatening complication. Sulfonylurea is cheaper but causes weight gain and hypoglycemia, so it's not good. Pioglitazone, it's not recommended in heart failure, bone fracture, bladder cancer, you know. It's not a good drug for that. It doesn't cause hypoglycemia, but it can cause retained fluid. So that's why some people can use it in renal insufficiency with diabetes. You can use that retained fluid. Sitagliptin have low risk of hypoglycemia, weight neutral as well. Doesn't increase the weight. And there's exenatide, low risk of hypoglycemia. Okay. And you can do a second line if metformin fail. Okay. Or if weight loss desired. So GLP-1 agonists can cause weight loss. Okay. So that's why I just recommended exenatide. It can decrease weight. A lot of people take it recently. So now somebody having hypercalcemia, okay, and they have fatigue, palpitations as well, and then you check the PTH. PTH is low, okay. So let's say this guy's 33-year-old man, okay, comes in with hypercalcemia, fatigue, PTH is low, and they tell you, okay, and maybe there's some osteoporosis as well. You check vitamin D, all of that, it's normal. So what's best next step? This one you want to check thyroid function test, TSH, okay? You want to do even thyroid panel, because this hyperthyroidism can cause palpitations, can stimulate the osteoclast activity, which increase the bone resorption and decrease bone density and increase fracture risk, and causes hypercalcemia. And this hypercalcemia suppresses the parathyroid hormone. Okay. When the parathyroid hormone is suppressed, you're gonna decrease calcium reabsorption, causes hypercalciuria. So in the net, you will have net calcium wasting. Okay. Other effects when you have low PTH, parathyroid hormone, you won't have conversion of 25 to 125 vitamin D. So the 25 vitamin D would have less of that, less of 25 vitamin D. So the GI system won't be able to absorb calcium. So this in return decreases renal calcium reabsorption and causes high calcium in the urine. So you have causes hypercalcemic hypercalciuria. So thyroid hypercalcemic hypercalciuria. Okay, this is interesting to know. All right. So another case is interesting. You see 55-year-old woman comes in with 2 centimeter adrenal mass and then hypertension, okay? So you have hypertension, 2 centimeter adrenal mass. What would you do? You do nothing? You just watch it, or you test for hormone? You test for hormone. Aldosterone to renin ratio. So you need the aldosterone to renin ratio. And you may ask why? Why? Because this is the workup for adrenal acidentaloma. Whenever there is a clinical and hormonal evaluation of adrenal hormone, this is whenever you see adrenal acidentaloma, you want to evaluate adrenal hormone. You check overnight dexamethasone suppression test, you check urinary catecholamine and metformin, and you check aldosterone to renin ratio if hypertensive. So you do all of these three if there is adrenal mass. If it's positive, you consult surgery after confirming the source, the mass is the source, and then they may end up taking it out. If it's negative, then you do imaging. You see the imaging phenotype. If suggestive of cancer or more than 4 centimeter, then you do fine needle aspiration and surgery consult. If it's not, then just follow up. Then you don't need to consult surgery. Okay. Now you see 34-year-old woman, fatigue, headache, weight loss, weight gain I mean. And what is best next step? In this patient, you want to do sleep study because it's likely obstructive sleep apnea. So what are the complications of obstructive sleep apnea? Like somebody with daytime sleepiness, difficulty concentration, fatigue, morning headache. You do sleep study. Why? Because if you don't treat it, it can complicate to resistant hypertension, angina pectoris, cardiac dysrhythmia, like waking up middle of the night, choking sensation. This is typical. Polycythemia, pulmonary hypertension, carpulmonal, decreased lipido, impotence. This is pretty big stuff, Alright. Someone have exercise hypoglycemia. What do you tell them? Exercise hypoglycemia. What's the best next step? You eat before exercise. Easy, right? Just eat more, even if you're diabetic, type 1, type 2, whatever. Just eat before exercise. Make sure you take enough fluid. Okay. Keep good snacks, If there's post-exercise hypoglycemia, you can use slowly absorbed carbohydrates so that you give you constant supply of glucose. And you can decrease insulin before the exercises by like 15% or so. Alright, now you have a patient who's like 44, have palpitations and tender thyroid gland. Okay, so you check the level. Free T4 is 2.5, TSH is low as expected, low TSH, high free T4, right? So what do you do? Best next step, you do beta blocker, right? And what else after that? What do? You do prednisone. Okay. Why is that? Because this is decovariant thyroiditis. Okay, tender thyroid hyperthyroidism. You give beta blocker and prednisone. You can also do high dose ibuprofen, like 1200 to 3200. Okay, milligram per day, and then you do prednisone, like 40 milligram per day. You do ibuprofen, 1200 to 3200 per day, Now this thyroid nodules is a very important question. You see 30-year-old having hyperechoic nodule 2 centimeter by 1 by 1.5, and then so you do thyroid workup. You do TSH. TSH is low, 0.12. T4 and T3 is on the higher side. So what would you do for this patient? Low TSH, thyroid nodule, low TSH. Okay, you do after the ultrasound. What do you do? Best next step, you do radioactive iodine scintigraphy. Okay, because this one, if tells you if it's cold nodule, then you need to FNA needle aspiration. If it's hot, you just treat as a hyperthyroidism. You don't need biopsy. Okay, this one you're trying to avoid the biopsy. But if the TSH was high, then you just go to the biopsy immediately. Okay, based on the size and ultrasound finding as well. So for cold nodules, when do you need the biopsy? You need it if there is high risk findings on ultrasound, like microcalcification, increased vascularity, hypoechoic appearance, and more than 1 centimeter. If it's low risk on ultrasound, but it's monitored and the thyroid nodule grows, then you need biopsy. If there is a purely cystic nodule, then you don't need a biopsy as well. Okay, and high risk patients as well, if they have first degree relative of thyroid cancer, you need to biopsy these patients. Okay. Okay. Now this question, they ask you, patient with celiac disease. Okay. What labs do you see in somebody who has celiac disease? Okay. You see low phosphate, normal calcium, and high alkaline phosphatase, and high PTH. Okay. So you may ask yourself, why is that? Because you have vitamin D deficiency in celiac disease. Vitamin D deficiency, what does it cause? Decreased calcium absorption and decreased phosphate absorption. So decreased phosphate absorption, phosphate goes low. But when the calcium goes low, what is that? You have hyperparathyroidism. Hyperparathyroid hormone would go up. So when the parathyroid hormone go up, what does it do? Increase bone turnover, release calcium from bone, and increase alkaline phosphatase. And this in turn causes normal calcium. And then you have low GI phosphate absorption, and increases renal phosphate excretion as well. Okay, so it's very interesting dynamics. We have celiac disease, calcium goes down, and phosphate goes down when there's no absorption, right? So when those both go down, parathyroid hormone goes up. Parathyroid hormone is called phosphate trashing hormone as well. So get rid of the phosphate, so phosphate even drops even further. But it goes to the bone and bring the calcium back to normal. Okay, so it's a very interesting physiology, right? That's the difference. Alright, let's do 2 more questions. Okay. So this case is 59-year-old, have heart failure on spironolactone, right? Because of improved mortality, right? But developed the breast gynecomastia. What to do? You do switch to iplerenone. It has the same mortality benefit and doesn't cause the gynecomastia. Okay, so it's good stuff. Okay, now you have a patient 23 having palpitation, weight loss, TSH like 0.0005. Okay, free T4 is like 4. This is very high, right? There's increased uptake. It's like 56%. Normal is like 10 to 30%. So what do you give? You give beta blocker and prednisone. And then tell you what's the next step. What do you do after that? You see this complex management. You add methimazole, okay? Easy peasy, okay? So that's kind of the management of thyrotoxicosis. This is Graves' disease. So how do you manage a patient with Graves' disease? You give antithyroid drugs if there's mild hyperthyroidism, older patient with limited life expectancy, or to prepare for radioactive iodine or thyroidectomy. And if you're pregnant, you do PTU, propylthiouracil, in the first trimester. And then you also do radioactive iodine in moderate to severe hyperparathyroidism, and sometimes patient preference. If the patient is fine with taking the thyroid out, so you do thyroidectomy, especially for large thyroid goiter. If there is coexisting primary hyperparathyroidism, that would be even better, you know, because that's a risk. You take the parathyroid hormone, but if you already don't need the parathyroid hormone, just take both of them. Severe ophthalmopathy, retrosternal goiter with obstructive symptoms as well can cause that. Okay. So let's review. We talked about Graves' disease, iplerenone, gynecomastia. We talked about alkaline phosphatase and celiac disease dynamic with calcium. Scintigraphy is helpful if there's nodule and low TSH. Prednisone is for decovariant thyroiditis. Eat before exercise if you're hypoglycemic. Sleep study. Aldosterone-renal ratio for incidental hypercalcemic hypercalciuria. Pediatric surgery, we know that we check thyroid function test and pericardial effusion, rosuvastatin for triglyceride, stress dose steroid if you're taking steroid, low fat diet is important, and orlistat. give iron for iron deficiency anemia diabetic. Late night salivary cortisol, and you need 2 cortisol tests to confirm Cushing. And then osteoporosis caused by leuprolide, and TSH 2.5 levothyroxine high causes osteoporosis, and factitious thyrotoxicosis can be caused if there's like low TSH, low T4 as well, and high T3. This could be factitious. And that concludes our summary of the second section of endocrine. Thank you for listening.